All right, well, thanks for coming out today. We have a wonderful presentation lined up for you guys. Our speaker is Al Otero. He's a physician's assistant with Alliance Family Physicians. Okay, he was here last year. For those of you who were here last year, I think he spoke on heart disease, and he did a fantastic job, so we asked him to come back again this year. All right, so without any further ado, please welcome Al Otero.
Hello. It's actually good to be back. I see some familiar faces. Yeah, the topic today I was asked to speak on was GI complaints, so gastrointestinal complaints. And I went ahead and put a little slide presentation together. And as I was putting this presentation together, I realized this thing, it's a lot of information. And more information that I got bored with it, so I don't want to bore you guys with it. And so what I did was I kind of I gleaned through a lot of the things that I see in clinical practice with upper GI and lower GI issues. And I figured I'd go ahead and bring that to your attention. Some of the things that you should be looking for, symptoms that you should be paying attention to, and things that you shouldn't dismiss. If you notice it's either you or a family member, and when it's time to really seek medical attention for any of these things. And so we'll go ahead and start out with the upper GI. And different places define them differently depending on what text you read. But the upper GI basically is the stomach and the first part of the small intestines. The lower GI is basically everything after that. I'm going to show you a picture here in a second. And so for the purpose of this talk, I want to separate them out, upper GI and lower GI, so again, so we know what to look for if you're having a problem and the things to be paying attention to. Again, not just you, but also a family member or a friend. I don't know if you can see this picture very well, and you don't really have to memorize any of this stuff, but when we talk about GI, if you go see a specialist, a gastroenterologist, they cover everything from mouth to butt. That's the whole GI system. And so we're going to start at the mouth, and we're going to end up down there. And so everything starts right up inside here, from the time you eat and swallow down through here, into the stomach, into the small intestine and large intestine, and then out through there, okay? Again, quick, dirty, easy, nuts and bolts. First thing I like to talk about is just the oral cavity. If you look at the picture here, and obviously you don't need this to tell you what your mouth looks like, what your throat looks like. You guys can see that every day. What's important is the function of it and what it does. Now, sometimes we take for granted that we eat, we bite, we chew, we swallow. But sometimes things can go wrong inside here. Rod was telling me you had someone that spoke, I don't know if it was last week, about dry mouth, and then about sleep apnea. And so, and that's why I said these topics could be so cumbersome. I want to try to get through some of the basic stuff. And the main thing I want to talk about is if you're eating and food gets stuck, or if it hurts when you swallow. And so, first part here, the medical term for problems with swallowing or pain with swallowing is dysphagia. Some of the common causes of dysphagia. GERD. Anybody here know what GERD is? Right? Gastroesophageal reflux disease. It's a common term that we use in medicine. A lot of times I use it if I know somebody has reflux. We don't know specifically what's going on and causing it, so we give it this definition here. Let me go to the next one. Stroke. Now, a lot of people don't think about stroke if someone says they have trouble swallowing or pain swallowing. But believe it or not, that's one of the indicators. Besides working in family medicine, I also work in the emergency room. And if somebody comes in of the right age, I won't mention that age yet, but if someone comes in and says, yeah, I've been having some trouble swallowing here lately, first thing we're going to do is go do a CAT scan of their brain. And it seems like, well, why are you doing that? It's trouble with swallowing. I don't have anything wrong with my head. That could be the first indication that you're having a stroke. And so that's just one of the things to look at. We're not talking about stroke today, but I just want you to be aware that somebody's having trouble swallowing. It's not going to be a benign thing. Really pay attention to that. Esophageal spasm. And sometimes that can happen because of irritation, because of the first thing I wrote on there, which is the GERD. The GERD causes acid reflux. It irritates the esophagus, and it can actually cause spasm in there because it's a smooth muscle. This is very important also because sometimes we tend to ignore it. I can't tell you how many times I have patients come in and I'll ask about reflux. It says, yeah, I have a little bit of reflux, but that's no big deal. Are you taking anything for it? Nah, it's fine. It doesn't bother me. I'm okay. And they don't realize what's happening with that acid that's actually eroding the esophagus, and it can cause other long-term problems. And that's what we're going to be talking about today, especially with this esophageal spasm. And if I remember, I want to share a story with you of a patient I had that actually went through something like this and ignored it. And then esophagitis. And again, a lot of these things have overlap, a lot of parallels. The esophagitis just means irritation. Anyone here, and you don't have to admit if you have it, but do you know someone that has osteoporosis? Anybody? Have you heard of the medicine Fosamax? Okay. This is just one example, but if you recall, anybody who's on Fosamax, if you know someone taking Fosamax, they tell you to take the medicine on an empty stomach, to drink a glass of water with it, and then to sit up for at least 30 minutes after you take the pill. Do not lay back down. Now, do you know why they tell you that? Anybody? Partly, but also because the pill and the coating is so irritating to the esophagus that if it gets stuck there, it causes irritation. So they want to make sure that you're sitting up, drink plenty of water, and get it into your stomach, where the lining of the stomach can actually handle that. That lining of the esophagus cannot. And we've actually seen problems with that, where it'll actually cause irritation in rare cases, but it has happened. It'll actually burn a hole right through the esophagus. That pill will. And so that's why it's important. And again, that's the reason why I'm talking about this, because acid reflux can cause the exact same thing. And so, again, I was talking about before how in medicine we separate the GI system or the GI tract, GI being gastrointestinal, into upper and lower GI. And so what we were talking about earlier is when you start and eat, you start in the mouth, and then as you swallow, it comes down the esophagus, goes into the stomach, and then starts making its first pass here in something called the duodenum or duodenum. After this is technically what starts the small intestine. And so each of these parts of your body have a specific function. And that's why they have different tests that they do. Some they do upper GI series. I know this probably sounds familiar to most people here. They have what's called an upper endoscopy. We'll talk about that in a minute. They have a lower endoscopy. And I've had patients ask, why so many tests? Why can't you just do one test to check everything? Well, it's physiologically impossible. These intestines are so long, there's no way you could do it with one test. I remember going through gross anatomy, and we actually took the intestines out. You probably don't want to hear this. Anyway, I'm going to finish. We take the intestines out of a body, and it's stretched from one end of the room to the other end of the room. You can't even imagine that that thing curled up fits inside of the stomach here. It is very, very detailed. And the small intestines are responsible for absorbing the nutrients and everything else. Large intestines reabsorbs the water. That's why we have solid stool that comes out. So if you have diarrhea, that's another problem. We'll save that for another lecture. So the thing, again, with the upper GI, we talked about, again, the esophagus, the stomach, and then the duodenum. These are some of the most common diseases we see in the upper GI. Ulcer. Most people know about this. We know how it's caused, for the most part. Stress is a big one. Most people probably have heard that. Stress will cause ulcers. Ulcers basically is an overproduction of acid, more than the lining of the stomach can handle, and it causes erosions inside there. That's why you could buy stuff over the counter like Zantac, or you could get the wonderful purple pill, Nexium, which is now over the counter, or Prilosec. And all of these things work a specific way to reduce the amount of acid in your stomach. Now, why is it important? Well, let me go through this real quick, and then we'll talk about that in a second, why it's important to take those medicines. Hiatal hernia. I don't know if people really know what a hiatal hernia is. What happens, if you were looking at that picture earlier where the esophagus goes into the stomach, or becomes the stomach, it has to go through your diaphragm. There's an opening in the diaphragm that this thing actually goes through. We call that a hiatus. In medicine, they actually call that opening a hiatus. And so that it's a hiatus for the esophagus, so we call it the esophageal hiatus. What happens if you get a lot of acid production in the stomach, a lot of irritation in the stomach, part of that stomach tries to push up through that opening, and it's not supposed to. It's supposed to stay below. Everything has its place in medicine and in the human body. And the definition of a hernia is when something tries to push from one side to the other where it doesn't belong. In this case, the stomach tries to push up and tries to come to the top where it's not supposed to be. We call that a hiatal hernia. And again, that's treated also with acid medicines, but in some cases where it's real severe, they actually have to go in surgically and repair this. We talked about this already, the gastroesophageal reflux disease. Barrett's esophagus. If you take nothing away from this particular section, this is the one I want to pay attention to. Barrett's esophagus is a precursor to esophageal cancer. What happens with Barrett's esophagus is you have the acid in your stomach is coming into the esophagus, again, where it doesn't belong, because the lining of the esophagus is not designed for the acid that's in your stomach. It's just like pouring gasoline in a styrofoam cup. I don't know if anyone's ever done that. I have. And it eats right through that styrofoam cup. But it won't do that to your gas tank because your gas tank is designed to hold gasoline. The styrofoam cup is not. So imagine your esophagus is like a styrofoam cup. The acid is not designed to be there. The acid is designed to be in the stomach. So when you have acid reflux or gastroesophageal reflux disease that goes untreated, you can actually develop something called Barrett's esophagus. So what's the problem with that? Well, by definition, cancer is when cells change into something that they weren't supposed to be. And so when the esophagus gets all that irritation from that acid in the stomach, it remodels. It changes the lining in there in order to try to protect from this new thing that's insulting it in the esophagus. Well, by definition, once it starts changing its cells, that's cancer. In fact, I had a patient this happened to. He had acid reflux for many, many years, went relatively untreated for a long time. I finally begged him to go have an upper endoscopy done, and we'll talk about that in a minute. He went, they said he had acid reflux, and he had already developed Barrett's esophagus. It had already been a little bit far gone, but they were trying to get it under control. He ended up developing esophageal cancer. He had surgery. They took out that part of the esophagus, but it was too late. He ended up dying about a year later from acid reflux. No one ever thinks they're going to die from acid reflux, and that's the whole point of this. And so the thing with Barrett's esophagus, on average, they don't know for sure. They say anywhere from 1.6 to 6.8% of the population at some point or another will develop Barrett's esophagus. That's why it's important to get tested. The average age of diagnosis is 55. Part of that could be because at age 50, as men and women, we start paying attention more. We start going in for more routine exams, start going in for more testing. It's very possible we could start sooner than this, but this is the average age of diagnosis. This is important. It says it's 2 times greater in men than in women. Don't know why. I don't know why that is. I don't know if men are just more stressed than women are. I have no idea. Women would argue that, but this is just one of the things that they found in studies. Men are 2 times greater than women. And in medicine, unfortunately, we do racially profile. It says there's a greater prevalence in white men than other races. I have no idea why. Again, when I read this, it doesn't say why. It just makes that point. I often jokingly tell patients that we do racially profile in medicine because there are some things, unfortunately, that are specific to race and gender. So now we're going to talk about the lower GI tract, and I said that has to do with the second part of the small intestine, the ileum, and then all the way through the large intestine. And there's a lot of things to worry about there. And again, I said there's a ton of information on all of this. The main thing I want you to walk away from with the upper GI is acid reflux, hiatal hernia, gastroesophageal reflux disease, and of course, Barrett's esophagus, and trying to prevent the Barrett's esophagus. So the lower GI is made up of the ileum, the large colon, and of course, everybody knows what that is. And then here's a picture again. When I showed you the stomach earlier, it kind of ends right about here. This is the start of the ileum. And then this is what I was telling you about, the small intestine, pulling that thing out. It's really, really long. And then it ends here, and then this starts the part of the large intestine. If you can see that tiny little tail right there, that's actually the appendix there. And so common lower GI diseases. Diverticulosis. How many people have heard of diverticulosis? Excellent. Diverticulosis is actually a pocket that forms in the intestinal wall. It's a weakening in the intestinal wall, and it forms almost like a small little balloon. By itself, it's not a problem as diverticulosis. What happens sometimes is food can actually get stuck in those pockets, sometimes corn, peanuts, things with small seeds can get stuck in there, and it can actually cause an inflammation, and that's when it becomes diverticulitis. So diverticulosis, no symptoms, but diverticulitis, very, very painful. Crohn's disease. Crohn's disease is, and again, I'm not going to go into too much detail with this. It's beyond the scope of what we're talking about, but this is one of the, not common, but one of the diseases you see in the large and small intestines. Ulcerative colitis along in that same family. These are just things that cause irritation within the lining of the colon. These are what we consider autoimmune diseases, and for this you have to see a specialist. Chronic constipation. Believe it or not, this is one of the indications for having the colonoscopy done. And a lot of times, and I know women for sure go through this more than men do, constipation. On average, I'll have patients who come in, and I'll ask men, how often do they go to the bathroom? Like clockwork, every morning with the newspaper. No problem, right? Guys can time their watch to when they go to the bathroom. But women, when's the time, last time you had a bowel movement? 3 days ago, 2 days ago, a week ago. Unfortunately, that seems to be very common. Constipation, well, the way we define whether or not you need to have testing done is if there's a change in your bowel habit. So let's say you're a woman, you come in and you say, well, I normally have a bowel movement every other day, but lately here it's been a week. That's a change. And usually at that point, I'm doing blood tests, I'm doing urine tests, and most likely sending you for a colonoscopy to find out if there's something going on that's causing that. Again, why do I make that point? Because even though constipation sounds benign, I don't want you to ignore it. Colon polyps. Colon polyps. I don't know if anybody here has had a colonoscopy, had colon polyps. I've had colonoscopy, I've had colon polyps. I went back 3 years later. My doctor said, come back in 3 to 5. I said, I'll be here in 3. I'm not going to play around with this. And so the next time after he went in, he says, okay, really, wait 5. You don't have to come back in 3. Because I've seen the bad side of this. Just like a mechanic puts the best oil in their car, they change their spark plugs, change their oil every 3,000 miles. I don't. But in medicine, I do pay attention to this. I get my colonoscopy when I'm supposed to. I don't want to die of colon cancer. Now, of course, I may leave here and die in an Al-Qaeda attack, but I'm not going to die of colon cancer if I can help it. And then, of course, colon cancer. Again, we'll talk just a little bit more about that in a minute. And then we'll talk about, again, more specifically, the large intestine. So in this picture here, we removed the small intestine, and this is the large intestine. Just for practical purpose of seeing where this is on your body, this is your right side. That's your right side of your body. Again, your appendix sits kind of the right lower side there. And then this first part here we call the ascending colon, the transverse colon, descending colon, and then you have what's called the sigmoid colon because it kind of has an S shape, and then it comes out here to the rectum and then the anus. Now, this is very important because when you have a colonoscopy done, and again, those of you who have had one, you know this, they take a camera and they go in through here, and they go all the way around in there. Sounds like it's very painful. Actually, it doesn't hurt at all. But it definitely shows you a lot because you can have polyps and even cancer hiding anywhere in here. A case in point, I had a patient many, many years ago that we had seen in practice, and the doctor I worked for at the time also did colonoscopies. And he had a patient that came to him, and she said that she had a colonoscopy done by someone else. They said everything was clear, but she was still having problems. And so he said, well, let's go ahead and repeat it. He repeated it, and he went up through here, went in through here, and then I don't know if you could kind of see, there's like a little curve there. We call that the splenic flexure. He turned the camera and went the other way and found the colon cancer sitting, hiding behind the fold in her colon. He saved her life. He absolutely saved her life because he took that time to take a look just right around the corner. And so sometimes in medicine, we may think we know what's going on, but my rule is to listen to you. If you come in and say, there's something wrong, I don't care what your tests say, I still feel like there's something wrong, then we just keep pounding the pavement until we figure it out. So I've learned that the hard way. I got to trust my patient, trust my patient. So rectal bleeding. Now, this is a big thing, believe it or not. We have a lot of patients who come in with us. And some of you, if you've ever experienced hemorrhoids, I know women who have had childbirth have at times experienced hemorrhoids. It could cause rectal bleeding. Sometimes it's easy to dismiss it just as hemorrhoids. In fact, these are the most common things that cause rectal bleeding. Well, let me back up there for a second. Let me just tell you this quick story before I forget. I had a gentleman come in one time who had rectal bleeding. and he had a history of hemorrhoids. We had it documented. We knew he had hemorrhoids. But his wife was really worried about him because she said it was different. He was acting different. Now, of course, he came in. I'm sure most men can relate to this. He's like, this is nothing. Just hemorrhoids, no big deal. And he said the only reason he came in was because his wife was pressuring him to come in, and he wanted to shut her up. And so he came to the office, and I said, hey, look, it's probably just hemorrhoids. Let's go ahead and check. It looked like hemorrhoids. I said, let's be safe. I said, let's appease your wife. Let's go ahead and get a colonoscopy done. I said, she'll feel better. I'll feel better. He said, fine, whatever. He really did not want to do it, but he knew his wife wouldn't let him alone. Did the colonoscopy. He had colon cancer. He came back in. We were able to get him referred, get it treated. When I saw him back, he was doing fine. He was cancer-free. And he had a whole different appreciation for his wife. Part of the reason is because she saw something different in him. She said she couldn't explain it. She said, he's not acting the same. Something is different about this. I don't feel right about this. I went on that. I could have easily have dismissed it and said, well, he has hemorrhoids. I see the hemorrhoids. That's it. He's done. No, I pushed a little bit further because she pushed a little bit further, and I'm glad that I did. If you ever see what they call black tarry stool, usually that means that there's a bleed somewhere higher up in what we call the GI tract, like in the stomach or maybe the first part of the small intestine. The reason why it turns black is because they believe on average blood that's coming from higher up, again like a bleeding ulcer, sits in the intestine probably 6 to 8 hours before it actually comes out. So during that time, it loses that coloration and changes. And it can turn black. Actually, I've also seen, and you've probably heard this, where they talk about coffee ground appearance in the stool, which can also be an indication of a bleeding ulcer. And so if you notice black stool, don't just write it off, oh, it's just black stool, and then move on. It could be telling you that something's going on in the upper GI. I did something wrong, Rod. Did I turn it off? Yes, I did. Okay. Awesome. The medical name for this is melena. Don't worry about that. I just threw that in there for me. Again, usually caused by upper GI bleeding. Blood stays in the intestines for about 8 hours. The most common thing we see is bright red stool. Why? Hemorrhoids. Hemorrhoids cause bright red bleeding. You'll see it on the toilet paper. You'll see it in the toilet. Other things that can cause it, again, the other name there, hematochezia. It could be caused by lower GI bleed, so something bleeding from the intestines. Remember, I showed you have the small intestine, has a tortuous path that it has to go. Then you have the large intestine, a little bit closer. So the closer you are to it leaving your body, the brighter red the blood's going to be. Hemorrhoids, again, most common. Honestly, by any measure, that's the most common reason we see. And by the way, most patients that come in who have bright red blood, who we believe have hemorrhoids, we send them for a colonoscopy, it ends up being hemorrhoids. Just so you know that, it's not everybody who comes in has colon cancer. I don't want you to think that, and I don't want to be a fear monger here, but I want you to pay attention to it because, like I said, that one gentleman would have been quick to ignore it, and I didn't want him to do that. Diverticulitis, we were talking about before, the pockets in the intestine. Something gets stuck in there, it gets inflamed, it causes diverticulitis. Diverticulitis is very painful. It actually will cause abdominal pain, and it causes it usually on the left side. Now, nothing in medicine is 100%, but for the most part, if you start developing left lower abdomen pain, fever, and you notice blood in the stool, there's a good chance you have diverticulitis, and you want to see someone immediately for that. Anal fissures, these are small tears. Sometimes this can happen with chronic constipation. Have to sit on the pot and have to push really hard. It can cause a small little tear. And of course, what we talked about just a second ago, the polyps. Cancer. So what's the purpose of all of this? It's to try to prevent this from happening. And so like I said before, there's all kinds of diseases that can go on in the gastrointestinal system, more than we could talk about here, more than I even know. But the more common things that we see all the time is the things I want you to take away from here today. Upper GI again. Most common cancers we see, I mentioned earlier, the esophageal cancer. I actually had a patient who had that. I had a patient that came in one time, he was 97 years old, came in to see me because he had the difficulty swallowing. And I asked him, I said, well, when's the last time you saw a doctor? He said, today. First time he had been to the doctor in his entire life. This guy was a farmer. I mean, he was in amazing health. 97 years old, didn't even look 97. And I told him, that's probably why you've lived so long, because you haven't been to see the doctor. I said, I would have found something wrong with you. so he was having trouble swallowing. That was his only complaint, nothing else going on. I thought for sure he was going to have esophageal cancer just because he'd never been to a doctor, 97 years old. Sent him for an upper endoscopy. He just had some swelling in there. They did a little balloon, opened it back up. He was back on the farm. I never saw him again after that. He did just fine. But that was one of those I thought there was something there, and there wasn't. But never assumed that. That's why I still ordered the test for him. Barrett's esophagus we talked about earlier. And then, of course, stomach cancers. And again, the difference is because the lining of the stomach can get overproduction of acid, can develop the remodeling there as well. If there's too much acid being produced there, it can cause stomach cancer. Acid coming up can cause esophageal cancer. And then we have, obviously, the cancers of the lower GI. Colon cancer, that's the big one. Rectal cancer, believe it or not, it is a little different. It's all based on where they find the nodule. And let me just talk a little bit about that just for a second with the cancers. Let me see if it'll back up for me. With the cancers, there are no symptoms early on associated with colon cancer. I don't know if you were here last year when I talked about stroke, or I think we talked about high blood pressure, cardiovascular disease. And I said for a lot of folks, your first symptom that you have high blood pressure is your stroke. Well, a lot of times here, the first symptom you have is when the cancer is so big that you can't have a bowel movement anymore. That's the reason why they recommend screening colonoscopies. The screening colonoscopies is to try to find it before you have symptoms. And now, we're conditioned that way. You know, you have chest pain, you go to the emergency room, you have a cold, you go see the doctor. We wait till we have symptoms. And for most diseases, that's okay. That works just fine. But for screening, like breast cancer, prostate cancer, colon cancer, you cannot wait till you have symptoms. You have to have a plan in your mind that you need to get screened and get screened at the appropriate times. In the case of colon cancer, age 50. Anybody above age 50, if you haven't had a colonoscopy, shame on you. Go get at least one. And almost every insurance company I know of will pay for the colonoscopy. I had the lousiest insurance. You can't imagine that, working in healthcare. I had horrible insurance. I had a $10,000 deductible before the doctor would even say hi to me. But they paid for my colonoscopy 100%. I made sure I got that done, 100%. And so if you haven't had it done, please consider it. Talk to your doctor about that. So that's where this comes in. The testing for up in the GI tract. The test for the upper, now they have different x-rays they could do, ultrasounds, upper GI series. The gold standard is something called an EGD. And this is just the upper scope. They put you to sleep. They give you some happy medicine. I love it. Here at North Florida, where I went, they use a medicine called Versed. It is wonderful. They pipe that stuff in there, and you are gone. I mean, and the doctor told me, start counting back from 100. I think I said 100, and that was it. I was done. When I woke back up, it was done. My wife is looking at me and said, you ready to go home? It was already done. It is the easiest thing to do. The reason why I tell you that, I have a lot of patients who don't want to do these tests because they think, oh, they're painful, they're going to be uncomfortable. Nothing could be further from the truth. These are some of the easiest tests to do, and those of you who've had it done, you know what I'm talking about. Colonoscopy is not to have a pun, but it is a pain in the butt. And it's not because of the test. It's because of the prep beforehand. How many people agree with that? The prep, oh my goodness, is horrible. I cried during my prep. I hated that prep. But the colonoscopy was nothing, same thing. They gave me the happy medicine. I was out. 20 minutes later, I was done. So some of the indications for an upper endoscopy: abdominal pain, acid reflux, a chronic cough. Believe it or not, sometimes that's the first time we find out you have acid reflux because you have a cough that just won't go away. There's other things that can cause that, but this is one of the things that we look at. And then for the colonoscopy, and again, I'm giving this to you because if you have these symptoms, if you're worried that your insurance won't pay for it, these are some of the more popular indications for having these tests done. The colonoscopy, abdominal pain, of course, constipation we talked about earlier, and of course rectal bleeding. It doesn't matter how old you are. If I have a 25-year-old that comes in, they say they have rectal bleeding, no history of hemorrhoids, no history of anything, I'm getting a colonoscopy done. We've seen it happen. It's rare, by the way, but we have seen it happen. And of course, family history. If someone in the family has it, That's the best reason, if ever, to go ahead and have a colonoscopy done. And so, where to start? Pretty straightforward. You start with your doctor. Schedule an annual exam. And go in, and if you're 50 and up, already going anticipating it's going to be a recommendation to have a colonoscopy. If your doctor doesn't recommend it, then you suggest it. Again, easy test, other than the prep. Prep is horrible. But the test is easy. Sometimes your doctors, after they see you for a visit, they may do a physical. They may send you home with these little cards, the stool of coke cards. And those things are a pain to do as well because, well, if you remember how to do it, you have to actually take a sample of your own poop and put it on this card and then send it back to the doctor. This is actually really important to do because those cards will pick up blood you can't see. You actually may have rectal bleeding and don't even know you have rectal bleeding. This is probably one of the best non-invasive ways to check. Is it 100%? Absolutely not. It could be one of those days you may have colon cancer and just not bleeding. But it's better than doing nothing. So if they give you those cards, take them home and do them. It may save your life. So, is there any questions? Yes, ma'am. Yes, ma'am. That is an excellent question. Shame on me, I didn't cover that. She was asking, we talked about the upper GI, the lower GI, but not the small intestine. Is there any way to test that? The upper scope stops at the stomach and the duodenum just because of the size. The colonoscopy stops, that picture I showed you earlier, at the ascending colon. And again, just because of the size, it can't get into the small intestine. The test that they, in the past, that was kind of the gold standard was something called an upper GI with a small bowel follow-through. So it's actually an x-ray. They have you drink some barium, and they take a picture, and this barium goes through the small intestine, and that's how they get the picture of the small intestine. But there is really a cool way of doing it now. It's been going on for the last couple of years. Insurance companies don't like paying for it because it's expensive, but it's a great test. It's a little camera that comes in a capsule that you swallow. And it just looks like a pill. And as it's going down, it's snapping pictures. I can't remember how many per second. And all the way down your GI tract. And it goes to the entire small intestine. And then when it comes out, and you can imagine how it comes out, you have to get this thing, bring it back to the doctor, clean it off first, bring it back to your doctor. It has a chip in there. They plug this thing in, and it actually gives them what amounts to a motion picture of your intestines. It is the most amazing thing I've ever seen. My GI doctor actually showed me. I didn't have it done. He said I didn't qualify for it because my insurance wouldn't pay for it. But he said it's kind of like the new thing now. I say new, it's been several years, but it's still a fairly new thing. And what it does, it takes all those still pictures that it takes, it puts it together, and it runs it like a motion picture. And it shows the small intestine in detail like I've never seen before. Absolutely amazing. And so if there's ever concern for small intestine disease, like I said, they could go in with a small bowel follow-through, or maybe do this little capsule. And there's probably other modalities that they have. It's beyond my pay grade. So I don't know the other tests, but those are the basic ones I know that I would refer for. So, yes, sir. Thank you. Excellent point. He was saying we would talk about stomach ulcers, and we would talk about something called H. pylori or Helicobacter pylori. It's actually a bacteria that they found years ago that they believe causes stomach ulcers. Now, not everyone that has a stomach ulcer has H. pylori. And not everybody that has H. pylori will necessarily develop a stomach ulcer. But there's some studies to suggest that if you have H. pylori and it causes a stomach ulcer, you have an increased risk of developing either gastric cancer or esophageal cancer. There's a couple of simple ways to test for that. There's a blood test for it. But also, if you have that upper endoscopy done, they'll actually do a small little biopsy. They'll take a piece of the lining and they'll test it for H. pylori. Great question. And the treatment for it, they use a combination of antibiotics plus one of those pills I told you about, either Prilosec or Nexium. So, any other questions? Yes. Oh, so yes, sir. That's another good question. He was asking if you hear all the advertisement about stomach acid or heartburn and having to get rid of the stomach acid. He's saying if you overdo it, can that mess up the composition? Absolutely. we need our acids as part of our digestion. And so, in fact, there's some studies to suggest that long-term use of those PPIs, Prilosec, Nexium, and medicines like that, can actually cause problems with absorbing calcium, lead to osteoporosis, and cause other issues like that. This is patients who have been on them for years. And so now the recommendation, and we'll get letters all the time from the insurance company, is that if a person's been on one of these medicines for so many months, and if we feel like their symptoms are under control, to actually start using the medicine as needed, not every day anymore. And it's for that reason. In fact, my doctor, I was on one of those medicines. He had me switch to Zantac, over-the-counter Zantac. And he said that was working fine for me. I didn't need as strong of a medicine anymore like the Prilosec. And same thing. It's the same recommendation, not to overuse those either, to get you to a place where your symptoms are controlled. Keep in mind, and that's why the upper endoscopy is so important, if you have something like a Barrett's esophagus, all bets are off. You have to be on those medicines every day because the malabsorption is lesser of an evil than the esophageal cancer. So it really depends on what it is that you're treating. It's a great question. Yes, ma'am. Yes. Right. That's a good question. I have no idea. Let me defer to my nurse. You don't have to get up here, but she has a degree in nutrition. I figure maybe she may know about this. Okay, so she was saying the live bacteria, the probiotics are usually in the yogurts, not in the pill form. Is that right? Okay. Yes. Oh, I love that question. Things that I have read, and the question was about probiotics. If you're having no GI complaints, should you still take probiotics? Many, many years ago, doctors used to poo-poo anything, no pun intended, but they would poo-poo everything that was not a prescription and FDA approved. Well, they've kind of been relenting on that a little bit, and they found that there are things that actually work really well, like chondroitin for the joints and probiotics. There's a balance that you have in your body, which someone was mentioning here with the acids. And a lot of times things that we eat, things that we do, being antibiotics, things like that, mess up that balance. And there's a lot of studies to suggest that the probiotics help to bring back that balance, whether you're treating anything specifically or not, taking it almost like a vitamin. Now, more specifically, if you've been on antibiotics, they definitely recommend being on probiotics. You'll even see doctors now prescribing probiotics if they've given you antibiotics, or a recommendation to buy some over the counter. It's becoming that popular now. So, there was a question in the back. Yes, ma'am. Oh, okay, yeah. Yeah, and have you had an upper endoscopy done? Okay, so that would be the only next step I would say, and of course that's between you and your physician. That's my legal disclaimer. That's between you and your private physician. If they say, yes, go ahead and have an upper endoscopy done, I mean, I personally recommend doing it at least once. If you're on any medicine for acid, someone at some point should at least look in there and see what's going on. If for nothing else, to rule out things like I said, Barrett's esophagus, gastric carcinoma, those kinds of things. And then if there's no reason to be on it all the time, again, the national recommendation, this even comes from the GI Society, is you can actually start skipping days, skipping 2 or 3 days, just whatever is comfortable. But again, it's whatever you and your doctor decide. The symptoms? Yeah. And that's why I say you kind of have to look at what's the lesser of the evils, having the symptoms or the potential risk of affecting the absorption of other things, like calcium, for instance. Yeah. Yes, ma'am. Low digestion? Oh, slow digestion. Yes, it can. But again, that kind of gets into a whole other area of the GI. They have different tests that they do to check digestion. They have something that's called dumping syndrome. You shook your head, yes. Things like that obviously are affected by that. that sometimes people can sit and food sits in their stomach for hours and it's supposed to be digesting. They have tests that they can do to run for that and ways of treating that. By the time it gets to that point, I've already have the patient referred to the specialist because that just kind of goes beyond what we do in family medicine. So, any other questions? Excellent. Well, thank you, guys.
Wasn't that a fantastic presentation? And the thing I love about it most is that the information that he gave us today can actually save a life. So it was, thanks again, Al. We're all done. I don't really have any housekeeping things other than to let you all know. Go ahead and call, get scheduled for your final fitness assessment. Next week, we'll be back here. Again, same time, same place. Wayne, do you have anything you wanted to add to? Okay, nothing from Wayne. All right, guys, that's it. Thank you. See you next week.